Excellent.
Welcome. Good afternoon. So the topic I was given was viability of oncology practice or clinical practice. And it kind of begs the question of what do we actually want to preserve and what is working and what is not. So I thought I'd start off with a quick assessment of what's good and what's bad with our current oncology care delivery system. Some of those have come by already. But when the slide comes up on the left, you see good, and the counterbalance with bad. And the first good is the quality of cancer care delivery. And I have to say, I think that the quality of cancer care being delivered in the United States is good. I mean, it should be better, but I don't think it's a bad situation. But the problem is we don't measure it. That's an assumption. We don't do a very good job of measuring how good it is, how good the quality is. And if we don't measure it, we can't improve it. And that's the main point. Here we go. Okay. All right. What happened? Can you bring that back? Okay. So, right. So quality is high, but we don't measure it. And if we don't measure, we can't improve it. And we should have a culture of continuous improvement. So we need to work on that. On the bad side, the value is not there. So while we may be doing good things, we don't really know if we're doing too much of a good thing or not enough of a good thing, and clearly it's leading us to bankruptcy. Access to new diagnostic and therapeutics is very high. As soon as something hits the market, as soon as the FDA approves it, it gets taken up very well, but there's very poor control of adoption. So it may be approved with an evidence base that speaks to a certain indication, but at that point, once it gets out, it begins to get spread, disseminated, used, and in some cases abused. So we don't have a way of controlling how this gets into practice and whether, in fact, that's a good thing or not. And some of the discussion on comparative effectiveness that Diana mentioned, talks to our need to do that. It does support clinical trials. Are about half of the patients who go on NCI cooperative group studies come from community practices, but still, it's low volume and there's lack of diversity. So our evidence base on our clinical trials is based on a narrow spectrum. It doesn't really accomplish the healthcare disparity population, the elderly population in good volumes. And so that speaks to the lack of uncertainty about how this really plays in the real world. Again, the comparative effectiveness answer, we hope. There's good access to care. There are lots of oncologists, but there's fragmentation of care. Cancer is a multidisciplinary disease, and so there are surgeons, radiation, and medical oncologists, but there are very few healthcare systems. There is warranted variation in practices. So what do I mean by that? If we all did the exact same thing all the time to all our patients, we would have very uniform results, but we wouldn't really learn if something was good or bad. And so having some variation is sort of a natural experiment that you can study and say who has better outcomes, and maybe this way of doing something is superior than some other way of doing it. So we do have variation, and hidden in there is some warranted variation that could be mined through rapid learning healthcare systems and other mechanisms. But it requires that you measure the outcomes. So if you're not measuring outcomes, you really don't know if someone has actually found a better way, a better mousetrap or not. And most variation, I think, is unwarranted. So if we actually measured outcomes, we would probably find that most of it really isn't justifiable. Precision medicine has arrived. You heard that all this morning. But there's some problems here. One is cognitive overload. That was mentioned earlier. Can a practicing physician actually understand the massive information and make rational decisions, let alone explain that to a patient in a way that the patient could decide whether or not they wanted to take that therapy or not. And we don't have good patient profiles. So we don't have good capture of molecular characterization of cancer diseases. And if so, how do we identify patients that might fit a clinical trial or might have the best combination of targeted therapies? Finally, on the good side, we have rapid adoption of electronic health records, but we have non-transformative design of health information technology. So what we've done is basically replicated a paper chart in digital format in a way that doesn't allow us to learn and doesn't allow us to aggregate our knowledge. So what does that bring to? It brings us to the ugly. Large segments of current oncology practice are not viable, and more than not viable, are undesirable for 21st century healthcare. It will take significant will and resources to redesign this, and resources means capital, which is not present, which is ugly. System engineering management is largely missing. We started to talk this morning about the contrast between basic science, where you want this kind of free go out and explore, versus an engineering moonshot. Let's get a man on the moon in 10 years. Let's just have it happen. But I think as we get closer to patient care, we really need to have more and more system engineering, human factors, those kind of things built into the system. And the transformative use of health information technology will be dependent upon data liquidity, which is the interoperability, the ability to have an electronic record that speaks to another record that can be uploaded into a data warehouse, and with what has been mentioned as semantic accuracy. So we need good data that we understand what it means, and we also have the willingness to share that data. So a couple of points here. ASCO has done in the last 2 years an oncology census, which we've sent out to our members. We tend to do this every year to give us comparative data. The point of this slide is to show that in 2012, 61% of responding oncologists, and there were several thousand of them, said they had an advanced electronic health record. Advanced meaning really capable of as robust as industry currently supports. A basic EHR would discount as being probably not much more than a billing system. And 15% said they were looking to implement in 6 months. We resurveyed them this year, and it's now up to 68%. So I would say we are at a tipping point. There are enough oncologists who have good electronic records that we can begin to think about how we can use that. Another slide, getting to the question of is there a viability in oncology practice or at least community practice. We asked the question, how likely are you to merge, basically? Are you likely to merge with another practice? 16% this year said they were. How likely are you to be merging or selling yourself to a community hospital? 26%. And for an academic medical center, 17. So you can see that over 50% of responders indicated some degree of what we interpret to be financial stress and a desire to consolidate into a larger system. And year over year, those numbers have increased overboard. So I think we are looking at larger healthcare delivery systems, which is not a bad thing. It may address the fragmentation issue. It may address some of the resource issues and the system engineering management need. So what is a systems approach? I think it has these 4 components. You have to have an underlying structure, which involves access to capital, efficient management of resources, quality standards, and governance. These things are best done on a large system-wide level because they're leveraged. They're leveraged across oncology, they're leveraged across pediatrics, across the OR. It would be silly to duplicate that for every service, but in a large system, it makes sense to have this in play. It means you have to have attention to your process of your delivery of care. So you drive towards standardization, you use production manufacturing principles of lean management, value stream mapping to remove redundancy and waste, look at variation. It requires, and this is the most difficult part, a culture of change. So now you're talking about change management and having people all agree to row at the same time, to the same cadence, and outcomes measurement. So I'd like to talk a little bit now about the health information technology. So we've talked about the need today several times of getting information, having it meaningful, having it understandable, having it in a way that can be shared. And this is ASCO's vision, is to create digital cancer documents. This is a component of rapid learning, but this is not rapid learning. But just the need to have a central document where the patient's information about chemotherapy, pathology, radiation, surgery, and patient-reported outcomes are in one place, and that can be passed if there's the will to share, can be passed. And so ASCO has created, I'm going to take you around this slide a little bit. So ASCO has created a structured document where we collected all the information that we thought a medical oncologist would want to know in terms of pathology information, details of radiation and surgery, and chemotherapy. It may not be everything a radiation doctor would want or a surgeon would want, but we created a treatment plan or summary document initially in paper form, and we've now converted this into a digital format. So that gives us the content. But once you have the content, then you have to figure out how you're going to message that in a digital format. And so we went to HL7, which is the standard setting body for medical informatics, and we petitioned and they approved us creating a draft document for cancer information. That draft document and implementation guide was just balloted and approved about a month ago. So now we have a document here that can be used. In California, the ONC has funded the California Department of Public Health to create what they call patient-centered disease documents to help as a breakthrough for treatment of chronic diseases. And the first chronic disease that the California Department of Public Health is starting with is cancer. So they are using our HL7 profile as the basis for creating this document file. The concept is that there will be a central repository in California which will have cancer data. So for example, if a patient arrives in an emergency room, the emergency room doctor could query this registry and find information about the patient. And this could potentially be available for data research as well and data aggregation. They are doing this work now. They're scheduled to make an interim report to ONC, which is funding this in January. So this is active implementation. On this side, we have the College of American Pathologists. And they have created, someone mentioned earlier, checklists, which are specified data elements that describe cancer. They created 81 of these electronic checklists, and they are looking to implement this now into electronic health records. This has been done in Ontario, Canada, but it has not yet been done in the United States. The Palo Alto Medical Foundation completed a pilot project in June, successfully transmitting cancer data for 4 cancers to the California Cancer Registry, which excites the registry because, as someone else mentioned, registry data is usually 2 years behind time and very, very inaccurate. If we can do this in real time, we would have achieved something significant. So we are working on this now. The CAP, we're also working with the College of American Pathologists in a new committee they've set up called the Biomarker Reporting Committee. So what we are doing with CAP is we are taking various cancer types like lung cancer and colon cancer. We've already completed and published that. We specify which biomarkers are clinically actionable and should be reported, as well as the various methodologies that labs can use and that are acceptable. Again, talking about this morning's discussions, how will we get this information? How will we exchange it? There is work being done by societies. And finally, patient-generated data. I put it out here because, we talk about the patient being centric, but really I don't think we're there yet. I think we need to bring the patient into the system. I am talking at a workshop next week with PCORI to talk about bringing cancer-related symptoms. We are talking about bringing in pain assessment for patients with metastatic disease, nausea with patients on chemotherapy, and to the point made by one of the questioners about rehabilitation, we are also separating out survivorship issues of depression, fatigue, and neuropathy.
Peter, last slide.
Last slide, okay. So the last slide is Cancer Link, which has been mentioned before. This is the rapid learning system that we are are developing at ASCO. I can take questions about it. So the three national policy issues drive oncology care through integrated delivery systems and what Michael Porter has described as integrated practice units, so we get some of the system engineering in place. Prioritize interoperable exchange of data elements, which I've just talked about, and then most importantly, create a sharing culture to support rapid learning system, which requires evaluating societal values, ethics, legal regulation, and economic incentives. Thank you.
Great. Thank you, Peter. We'll move on to our last speaker, Lee Newcomer, who's Senior Vice President of Oncology, Genetics, and Women's Health at United Healthcare, and will talk to us about clinical implementation and reimbursement of novel technologies.